Good afternoon. It's my pleasure to welcome everybody to this session with this very suggestive name, The Long and Winding Road, Latent TB Infection Testing and Treatment. Speakers have 8 minutes. We can make clarification questions immediately, but discussion will be to the end of the session, okay? We will tell the presenters 1 minute before their timing is finishing. So it's my pleasure to call Rain Hoban. Hi. He will present the global burden of latent tuberculosis infection.
I can't do anything on here, so someone bring... There you go. All right. Okay, I'm very welcome everybody. Thank you to the organizer for inviting me to speak. So I'm presenting some results from trying to re-estimate the global burden of latent TB infection working together with Pete Dodd. And the core question we tried to set out to answer is, was it really 1/3? Just to say at the start, this paper has just come out 2 days ago, so I only have 8 minutes, but if you want all the details in the paper and also in the 20 pages of supplementary materials that accompany it. So the reason to look at this is because the number 1/3 crops up almost everywhere. It's at WHO, the NIH, the CDC, and even the popular press in this country got whiff of it. So you know it's a number that's widely spread. Where this number came from is actually really unclear. And I have asked people, and the best guess that I got is that someone at WHO at one point turned over an envelope, took a pen to it, and it came with the number 1/3. A slightly more recent formal estimation happened with Chris Dye and colleagues in 1998, published in 1999, where they did find that on the global level, the total burden was 32%, and thereby sustaining in oral history the number 1/3. But things have changed since 1998. There's been a massive population growth in, for example, India, Nigeria, also areas with high TB burden, while at the same time, some countries have seen dramatic changes in their TB burden, such as China with the repeated prevalence surveys. What's also changed in the scientific insights. The previous estimate was based on the classic Stigler rules, which have one part of which have recently been challenged in, for example, work by Frank van Leth that shows the relationship between prevalence of SMER-positive disease and the number of new infections is actually quite a bit lower in the current era where there is chemotherapy available. So what we aim to do is to estimate the LTBI prevalence in 2014, estimated by country and aggregate up to WHO region. And the way we did this is to construct a trend for the annual risk of infection over time, fitting a line to either data points, using reviews from, using LTBI surveys from reviews by Cowthan and Bourdin-Trans, and also did a literature review to find more recent data. After 1990, we used the global TB program estimates of prevalence of disease with the revised Stigler rule as I just showed, and then adjusted this for the proportion of disease that would be SMER positive and by HIV status, because this Stigler rule applies to SMER positive TB. And then we added the ARI data points from literature search to overlap and see if there was any, if the two estimates came to the same point. We then also used, to build up a population, we used a demographic model from at least 1940 and further back up to 2015 to using UN population estimates. And then we combined these two into one model where we applied the ARI trend, so the risk of infection of every single year to the population over time. And that way age cohorts accumulate infections over time. For example, 15-year-olds in 2014 will have experienced every year from 1999 a risk of infection, and that then allows you to calculate what in that age group is the prevalence of infection. So the outcomes we looked at were the LTBI prevalence on the global WHO region level and also in children. We looked at recently infected within the past 2 years, as we defined it here, and also looked at recent infections with INH resistance, combining our risk of infection with the proportion of disease that would be INH resistant from GTB estimates. And we also just looked ahead a little bit to think about what would happen if this global burden was left unattended and what would that have an impact on the NTB strategy. So looking at what the incidence of reactivation would be of our current reservoir in 2035 and 2050, assuming rather aspiringly that all transmission would have stopped on the 1st of January 2015, so just the current pool and with a 0.15% reactivation rate as a number. Some of the key assumptions, just to highlight that we realized we did make some simplifying assumptions, is that we assumed ARI estimates were nationally representative, that we have a single ARI for everybody in that year, so homogeneous mixing, no effect on TB mortality, and treatment of TB mortality and treatment on the pool of individuals that all have a latent TB infection, and we assumed an infection was lifelong. Now, each of these could be challenged, but our reasoning was that we wanted, unless we could have a clear, quantifiable number that we should use, an assumption, or a number we could use instead, this keeping it simpler would be the preferred approach. We took into account protection from reinfection and looked going backwards from our data and look at a more linear historical trend in ARI, and these were explored in sensitivity analyses. Also, very importantly, we took into account uncertainty where possible. So uncertainty in ARI estimates, prevalence estimates, adjustments for smear positive and HIV, and protection against reinfection. All of these have uncertainty bounds, and these were taken into account during our modeling. So this is then the result with the global distribution of LTBI distributed across the different countries. But the core question, was it really 1/3? And the short answer is basically no. The actual number that in 2014 lies around 23%, just under a quarter, with a range around that. This slide just shows very briefly the results by region, where we see the geographical spread again. And it comes down to, in the end, 1.7 billion individuals currently carrying a latent TB infection, of which 100 million are individuals aged under 14 or younger. So the other question about what does this mean for our elimination and NTB strategy goals? So say, just repeating the assumptions, if we stopped all transmission in the 1st January 2015 and assume a 0.15 reactivation rate per year, it would lead to, we still have almost 1 billion individuals LTBI in 2035, with an incidence of 16.5 per 100K, which is above the incidence target in 2035. And these are just from the latent TB reactivation pool. And in 2050, we would still end up with an incidence of 83 per million, which is, as you can see, well above the 1 per million per year ending or eliminating TB target. So those are brief results, more in the paper, and I'm happy to have any discussion with people if they're interested. Just repeating our key assumptions, so that there is an ARI estimate, a national representative, etc., and that we did take into account some uncertainty in sensitivity analysis as well. The strength of the model is that it is a simple model and the clear assumptions. You may disagree with them, but at least they're clear, and you feel free to start shooting at me right after I stop talking. It's taking into account updated demographics from 1998, remember, the TB burden and scientific insights. We propagate uncertainty where we could, and we do match recent ARI estimates. There's a literature review, and our method of going from prevalence to ARI matched wherever we had data. And we also match recent LTBI estimates that are more directly measured, as in particular in the USA, a paper by Mancuso et al. Found the same burden that we found. So just thinking about what does this mean, we have 1.7 billion individuals walking around with LTBI, which is just under a quarter. And addressing this pool is vital for reaching the NTB strategy targets. The estimate is lower than in 1998. This can be due to various different factors. It can be the model is different, the demographics have changed, the TB burden has changed. And we've looked at this, and it is mainly the change in the modeling approach, the change in the Stibler rule, and also other assumptions that I can't really go into have an impact. And this approach that we feel is more appropriate, given what we know now, changes the burden quite dramatically. The question about what do we do about this 1.7 billion individuals, I think we're going to hear more about it in the session, but overall, our feeling is not really feasible to address this whole reservoir with current tools. And we need, therefore, new tools that prevent it either progression, the progression, or allow us to test and identify those in need of treatment and have a treatment that's much more acceptable at a population-wide scale. The impact, there's also a question about the future impact. It might be that if we reach the SDGs, people are healthier, they have improved nutrition state, for example, and the reactivation rate might be lower. The counter-argument to that is that the LTBI population will also be older. If you think about our model, in 2050, everybody will be basically aged 50 or above almost. And we'll also, the majority will still live, but will be a lower middle income country unless we eradicate poverty altogether. And also one thing to remember is that we didn't actually manage to stop all transmission on the 1st of January 2015. So therefore, this is an underestimate of the amount of LTBI and cause later on. I just want to acknowledge, I'm still within time, people from the TB modeling group who gave very valuable input on the model in early stages. And thank you for your attention. I'm happy to answer any questions.
Any clarification questions? Okay, thank you very much. I would like to invite now Morten Ruwald from Denmark.
I need somebody to help me switch the slides here. Voila. All right, so I'm from Staten Serum Institute, and I'll talk about a new specific skin test that we have been developing. I have the following conflicts of interest that are mainly related to my employment at SSI. So the current landscape of latent TB diagnostics is not very good, but this is what we have. We have the tuberculin skin test, field-friendly, cheap, but has this problem with cross-reactivity with BCG and NTMs. We also have the IGRAs. They are specific, but they are quite laborious to do and to analyze. So in this project, we try to combine the specificity of the IGRAs with the field friendliness of the tuberculin skin test in a specific skin test we call CTB. It's based on ESAT6 and CFB10, exactly the same antigens that are in the quantiferin and the T-spot TB. So the clinical development of this project has been ongoing for about a decade now. It includes 7 clinical trials, more than 3,000 participants, more than 700 kids, and more than 800 HIV infected. And of course, a lot of partners around the world. So we are currently at phase 3, and I will talk about 2 phase 3 trials in these 8 minutes I have been allocated. But before we could do that, we had to establish a cutoff for positive test. So here we did in phase 2 a comparison between BCG vaccinated people from the UK and patients with active TB from South Africa. And here you can see the PPD responses. This is the induration size on the y-axis, and in the BCG vaccinated controls you have some that are responding, but a nice separation between TB patients and controls. So with the CTB, we have a comparable size of the induration in the TB patients, but a lower number of BCG positive, or in the BCG vaccinated controls, a lower number of positive or responding individuals. And we could then put that into an RC curve analysis and identify a cutoff at 5 millimeters. And that cutoff we then took to phase 3 testing. And we did that in 2 trials. We actually did it in 3, but I will show you data from 2. And the first and most important trial was done in Spain. It's in the contact tracing setting. 13 centers orchestrated beautifully by Joan Calà and his group in Barcelona. So we have about 250 to 300 people in each group. We have unexposed controls. We have occasional contacts, so they would constitute cycle 2 and 3 in contact tracing, and then some close contacts that would constitute circle 1. And then as a positive control, we have TB patients. Looking at the induration sizes in the 3 contact groups, on top you see the unexposed controls. In the middle section you see occasional contacts and close contacts. You can see the blue bars, the PPD. We have quite a number of responding in the unexposed control in top, and basically no responding with CTB in that group. And then the lower you go, the higher the probability of being infected, and the higher probability, or the higher number of actually positive tests we're finding. And then when you look at the close contacts in the bottom, you can see this quite nice Gaussian distribution around 20 millimeters. We know that that BCG is the main driver of the unspecific responses with the tuberculin skin tests. So we split this into BCG vaccinated and BCG unvaccinated. And in the top panel, you can see the BCG vaccinated being nicely with the red CTB responses, nicely sort of stepwise increment associated with the higher risk of being infected, whereas the BCG vaccinated were quite a large number of them being positive in the low risk groups. We've over-exaggerated this a little bit by choosing a 5 millimeter cutoff. But applying the same 5 millimeter cutoff for the BCG unvaccinated, we see exactly the same performance between these two tests. Moving into the main efficacy comparator here, that's the quantiferin test. You can see the CTB still kept in red on the left and the quantiferin in blue on the right. The same incremental increase in number of test positives. Putting that into a 2x2 table, we have 834 that have both tests available, and only about 49 of these were discordant. And there's no sort of tendency for one test having a higher number of positive responders compared to the others, suggesting that these two tests are delivering kind of the same response. Of course, there's some discordance, but we would expect that because one test is measuring something in the blood and the other one is measuring something in the skin. The other phase 3 trial I have taken with in this presentation was done in South Africa by Kirtan Dita at 9 sites. It included TB suspects, not because this is sort of the prime group we would like to implement this test into, but in this group we will see quite a lot of positive outcomes, and that allows us to investigate the effect of HIV infection and also the effect of age. We also included 185 close contact children, so these were asymptomatic household contacts. And then we also had an endemic negative control population that I will not include in this short presentation. So looking first at the impact of HIV infection on test performance, we did a head-to-head comparison with quantiferin and the specific skin test. And you can see on the left, the HIV negatives, a similar number of positive responders. But in the HIV positives, we had 277 here. We could see that the specific skin test in the black bar was significantly higher than the quantiferin test. We then split that out on the CD4 T cell count because we know that the lower the CD4 cell count, the poorer these tests would be performing. And we can see that CTB remains quite robust down to around 100, where it has a drop in the number of positives, whereas the quantiferin seems more universally depressed and wobbling more, but again having the largest problem in the low CD4 cell group. Finally, I will show you some data on how these tests perform in children. And it's quite difficult to study how skin tests perform in, or how latent TB test performs in children. So here we try to sort of illustrate the impact of age by saying, okay, all those that had a response higher than 0 millimeters, if there would be a negative impact of age, young age, then there would be a gradual drop in the ability of these individuals to drive an induration in the skin. So here you can see we compare CTB with PPD, and around the age of 5, we start to see a drop with both tests, exactly as we had expected. And you can see here we've added the 5 millimeter cutoff for the CTB, so there's quite a wide gap before it becomes sort of a problem for the test, whereas the PPD you would use a 10 millimeter cutoff in the South African setting here, so that gap is less. So I think my time is up, but I will just conclude here that we have developed a new test that seems to correlate with exposure to MTB. We have similar performance with the quantiferin. The safety profile, I haven't talked about that, but it is comparable to PPD, and we're seeing local injection site reactions, as you would expect from a delayed type hypersensitivity reaction in the skin. We saw this impact by HIV infection on the test performance, but predominantly we saw that in the low CD4 cell count group. We need, of course, to confirm these data in other cohorts as well. Also larger cohorts with more in these low CD4 cell groups. And then we saw that the CTB was impacted by young age, but because we can use this lower cutoff, it seems, or it could be more robust. And finally, we set out to assess if this test could deliver an IGRA-like performance in a skin test format using a 5mm cutoff, and we think that we succeeded in showing that. So I'd like to say thanks to all the people at Staten Serum Institute who've been working on this project, and all the investigators, PIs in Spain and South Africa. And it's a huge effort involving a lot of people that are, too many to be on the slide. Thank you.
Any clarification questions?
I have a question. Thank you. I'm really delighted to see the results. The question I have is, you showed no information about the people who never come back for skin test reading, which in program conditions is a big flaw of having to require people to return for the reading. Granted, you're doing it under study conditions, so I would assume that would be minimal. But I also assume you didn't get a 100% readout of everyone that had a skin test done.
At least in the Spanish study, we had 99 point something. So, you know, they ran a very, very tight shop in Spain. We had, of course, lower return rates in South Africa, but it was still very, very high. But again, you know, with the quantiferin, you still need to call them back to actually give them the result from the test. So it's kind of inherent in any kind of test, but valid point.
I have a clarification question that I always have. How do you define an unexposed person in countries like South Africa or even
of course,
Spain?
you cannot do that. So that's why we always work in these very artificial settings here. So
it's a known exposure, right?
Yeah, so no documented travel exposure, no sort of,
Okay.
these kinds of exposure.
Thank you.
Yeah.
Thank you very
Thanks.
much. We are calling now Jason Stout from the United States to talk about performance of screening tests for latent tuberculosis in young foreign-born children using latent class analysis.
Okay, great. Well, good afternoon, and thank you very much for this opportunity to talk here. I think I want to do my acknowledgements up front because everyone falls asleep at the acknowledgements part. So this is the work I'm about to present was the result of work from a lot of people across multiple sites in the United States, and this is a CDC-funded Tuberculosis Epidemiologic Studies Consortium. So, there we go. So the essence of this is that, the last two talks were a very nice setup in a sense, because so in low endemicity areas, foreign-born children under the age of 5 are a key population to screen for latent TB, because if they can be identified, they have their entire lives to develop active TB, and so you can prevent a lot of future disease. Furthermore, they're at higher risk to develop active disease after exposure and infection, and nonspecific symptoms may delay diagnosis. They're a very important population. As sort of was alluded to, there's really no definitive diagnostic test for latent TB. A lot of people use surrogates of, well, you test sensitivity among people with confirmed active TB, which is kind of a different immunologic state, and then you try to find, quote, unexposed people, and you call them your negative controls, but there are issues with that as well. And of course, latent TB testing of young children is confounded by, especially in the foreign-born, recent BCG vaccination, which presumably leads to a lot of false positive tests. So the TB Epidemiologic Studies Consortium prospectively enrolled participants at high risk for latent TB from 10 sites with multiple subsites in the United States. And all participants had all the 3 commercial tests for latent TB performed, the skin test and both interferon gamma release assays. And for this particular analysis, we just examined the subset of foreign-born children under the age of 5 who were HIV seronegative, so 463. When I say foreign-born, I'm talking about foreign-born pretty much from medium to high endemicity TB countries. We tried to estimate test characteristics, the sensitivity, specificity, as well as prevalence of latent TB using Bayesian latent class analysis. And the way this works is a latent class analysis is a technique that is used, it's been used a lot in the social sciences, but increasingly in diagnostics when there is no gold standard, and you basically are using the patterns of test results observed to statistically come up with a statistical gold standard, as it may be. With Bayesian latent class analysis, it's a refinement of the technique that basically takes what you knew before, in this case information from the literature, that uses that as a starting point, and then updates that starting point with observations of the patterns of test results from your study. So in this case, we said, well, sensitivity, we have some data on sensitivity. And the data we used for sensitivity, where we looked at the very small number of prospective studies that looked at these young children at risk, did testing with any of the 3 tests, and then followed them to see who developed active TB over time, so you can estimate sensitivity of the test. So in this case, our estimated sensitivities are listed up here. So for the skin test, we found 131 children in the literature who had been tested prospectively and went on to develop active TB. 90 of those had a positive TST for a sensitivity estimate of 68.7%. And the credible interval is a Bayesian equivalent of a confidence interval around that estimate. For the quantiferon, estimated sensitivity before doing the study, 71% from the literature, and the T-spot's about 64%. For specificity, we didn't believe that any of the data in the literature were informative on this, because using, quote, low-risk populations as a surrogate, their test characteristics may be different. So we said, we don't really know much about this, so we're going to use what we call a very weak prior, which says that just as a very initial stab, we're going to say, pretend there was a study of 10 children done, and for the skin test, the specificity, we're saying maybe 70%, and the IGRIS about 90%. This is a very weak prior, so if you observe any data, it kind of washes this away. Okay. We also looked at the issue of conditional dependence on results, and what this means is all the 3 tests that we use for latent TB are based on immunologic responses. So they may depend on each other in ways that are not just dependent on the underlying frequency of latent TB. They may have dependence that is explained by the fact that they're all immunologic tests looking at similar things, and we tried to factor that into account. So this is the pattern of results. The thing that's most notable here, so in these 463 children, most of them were triple negatives, negative for all 3 tests, but the second most commonly observed pattern, about a quarter of the children had an isolated positive tuberculin skin test with 2 negative interferon gamma release assays. Other patterns were very rarely observed, and triple positives were about 9 or 1.9% of the children. So when plugging this into the latent class analysis, what you get out of this, if you look at the sensitivities here, you can see for the 3 tests in the bars on the left, all the tests, the sensitivity, the little X in the bar, that's the mean. And you're talking 60 to 70%. The T-spot looks a little bit less sensitive there, but they're all within bounds. And the specificity, you see a marked difference. That's the bars on the right. And that the specificity of the skin test, you can see down there in the mid-70s, and the specificity of the interferon gamma release assay is in the high 90s. Those are quite different. So the calculated prevalence of latent TB, again using this latent class analysis, in this cohort was 4.2%, and the sensitivity of the test, 68.8% for the skin test, 70.4% for the quantiferon, and 58.9% for the T-spot. The specificity, as noted in the graph, is 74% for the skin test, 98.9% for the quantiferon, and 99% for the T-spot. So when you bring this forward, what we really care about, honestly, when doing diagnostic testing is not sensitivity and specificity. We care on what's the likelihood, given this test result, that my patient will have latent TB or will not. So this gets to positive predictive values. And in this, the remarkable thing was in this cohort, the likelihood that you truly had latent TB, the positive predictive value, with a positive skin test was only 10%. 10%. For the quantiferon, the T-spot, it was better, but nowhere near perfect. 73.8% for the quantiferon, 71.9% for the T-spot. Conversely, the negative predictive value, which is the likelihood that this child who has a negative test does not have latent TB, was about equivalent and very high for all the tests, over 98%. if you look at test combinations, one thing that we can get out of this analysis is, okay, so if you have a particular combination of test results, what's the positive predictive value there? And what you see here is if you're triple negative, meaning all 3 tests are negative, some of those people actually did have latent TB, and that reflects the fact that all the tests are not perfectly sensitive, so about 0.5% of those had latent TB. Conversely, if you look at the triple positives, almost all of them had latent TB, 99.2%. The credible intervals for all the combinations in the middle are quite broad, except for isolated positive skin tests, and that relates to the fact there were very few children who had those combinations. But the most important thing to point out here, the positive predictive value of an isolated positive skin test with 2 negative IGRAs was 1.3%, which really was no different than if you had 3 negative tests. So the bottom line, the sensitivity of all the available tests for latent TB is really not very good in young children. Anyone who's worked with young children, I think, knows this already. Consistent with other observations, quantiferon and T-spot were found to be more specific than the skin test and roughly comparable in their sensitivities. Relatively low specificity and low latent TB prevalence in this cohort were associated with very poor positive predictive value for the skin test without any improvement with negative predictive value. And I think this is a crucial point because what people worry about is, am I going to miss a young child who has latent TB by doing one test versus the other? I think the answer we obtained here is no. They all miss some kids, but it's a very, very small number in this type of population. And so the conclusion that we came to is either the quantiferon or the T-spot would be preferred over the skin test for latent TB screening in this kind of population. All right. Thank you for your attention.
Any clarification questions? No, so thank you very much. Oh, sorry.
Maybe you said that, what is the copper value for PSD? That seems a bit false positive about if you consider increasing the cutoff, or was there no?
Yeah, the cutoff was the standard CDC cutoff. So for most of the children, it was 10 millimeters. Some small number were contacts, and it would be 5 for them. I'm sorry. Yeah, I'll just read it. So the question is, what conditional dependent structure do we use? So we used a modification of the random effects model of Chu. We looked at finite mixture modeling, but there are actually problems with that whole type of model. So we tried it. It would never converge, and after a discussion, we discarded that. Thanks.
Okay, thank you. We are calling now Dominic Zenner, who is going to speak on behalf of Miranda Lute.
Okay, thank you very much. Miranda, I'm not Miranda. Miranda is sick, unfortunately. So I'm using her slides and I'm guiding you through. This is basically a slightly different study. This is, I sometimes say, England is a bit of a guinea pig in programmatic LTBI screening, and we'll like to present some early data in showing you what our findings are. I don't have any conflict of interest other than that I lead on the rollout of LTBI screening in England. This is the epidemiology of TB in the UK, and what you see is, oh dear, right, here we go. What you see, and I can't show you because I don't have a pointer, is in blue the rate of TB amongst the foreign-born population, and in yellow the rate of TB in the UK-born population. And you see that the blue line, as well as the red bars, which is the numbers of cases, are much, much higher. So the importance that fleshes out the importance of TB in the foreign-born population in England than in the UK-born population, and that it recently came down slightly, and that the epidemic in the UK is actually really explained to a large extent by the epidemic amongst the foreign-born population. 3/4 of cases occur amongst the foreign-born population. This is a slide which shows you basically over the years the number of cases that occur and the time it took from entering to the UK amongst the foreign-born population and notification. And you can see two things. One is that the vast majority, now it's 60%, occurs more than 6 years after entry to the UK. But also this is an increasing trend. So basically over the years we see more and more cases reactivating later and later. And that might be to do with many things, including that we do pre-entry screening for active TB and other things such as tighter borders or whatever it is. But it is an important thing. Therefore, in the collaborative strategy for England, you can see that we included it into the 10 intervention areas, and you can see that new entrant screening for LTBI is just right there. This is the algorithm. I'm not going to talk you through, but in principle, it's an IGRA-based, primary care-based screening. So it's we either use quantiferin or T-spot to diagnose and then later on rule out active TB. And basically, for the latent TB, they get mostly treated in secondary care. In the pilot, I'm showing you the data on, it's in primary care. The pilot takes place in Newham. Newham is a place in London, which is almost on the meridian, and it's got a TB rate of about 100 per 100,000, very high, probably one of the highest, or I think the highest rate in the country, which is pointed out here. And in Newham, almost 90% of the TB cases were amongst the non-UK born, mainly from India, Bangladesh, and Pakistan. This is how this works, the screening algorithm in Newham, and you can see that basically patients are having an IGRA test, they then are called back to the GP, explain the results, and are referred and being treated in the community by community pharmacist. Those that have abnormalities are referred to secondary care. 59 GP practices, 21 community pharmacists. And these are the eligibility criteria. Very high incidence countries, more than 150 per 100,000. So here's some results. What you can see here is that amongst those, it's really a shame I haven't, here we go. Amongst those that have been tested, not everyone comes back and is keen to be tested, only 41% in this cohort. 21% didn't want to take up the test, and this is missing data. Okay, so this is the first. What we're talking about, this is observational, this is the real life world. This is not a trial or anything like that. This is what pans out. Of those 41% that had the LTBI test done, 32%, sorry, Rain, slightly higher, had a positive IGRA result in this cohort, and 68% had a negative result. 86% of those had then an explanation and were referred on, and 62% were prescribed treatment. So that's the treatment cascade. Here we go. This is our baseline data, slightly busy slide, I apologize, but what you can see is that mostly young adults here, roughly half female and male, and mostly from Southern Asia and Sub-Saharan Africa. Okay, the countries Bangladesh, India, Pakistan. That's the baseline cohort. Usually, most of them are relatively healthy. A few smoke, as you can see, but a few have pre-existing conditions. So we thought, okay, LTBI testing uptake, what does it depend on? And we did some multivariate analysis in that as well, and you can see that the first thing to say is if you're a current smoker, you're less likely, slightly less likely to take up IGRA testing, whereas if you have an underlying condition, you're more likely to take up IGRA testing. The other thing is that people from South Asia, South and East Asia, were more likely to take up IGRA testing than were less likely to take up IGRA testing than others. And those from Sub-Saharan Africa as well, as you can see. IGRA positivity depended on basically this is equal in males and females. There is some, of course, there's a higher positivity in Sub-Saharan Africa, and of course amongst some of the people with comorbidities, such as, for example, diabetes. A very important secondary effect of screening is that you find active cases, and I think that should never be forgotten. And so we had amongst these migrants 11 active TB cases identified, which gives a pretty hefty rate, 500 per 100,000. So that's not to be forgotten. That's prevalent TB cases that are detected early through the scheme. Referral uptake. So this is really interesting. Basically, to sum up this slide, you really don't see very much difference, apart from one thing that I'm not displaying here, which is that the provider made a huge difference to treatment uptake. So that is a lesson to be learned. We looked at delays in the patient pathway, and there were some testing. This is weeks, right? And so there are some delays, some significant delays.
You
which
have
are
1
important.
minute.
Thanks. And for treatment as well. But the delays, again, were more associated with GP surgery providers rather than the individual test providers. In conclusion then, so this is the first results from the pilot in Newham that demonstrates the need for robust data collection. And we're collecting as we go on. We've got mandatory data collection within our testing scheme. LTBI testing uptake, as I showed, is influenced by country of birth and health-seeking behaviors. IGRA positivity, more among men, older age groups, and people from sub-Saharan Africa. Treatment uptakes not influenced by any demographic factors other than provider. And improving patient pathways and awareness building is important to make this a success. There's been quite a few people involved in the pilot and also in writing up this data, and I'd like to thank them and you for paying attention. Thank you so much.
Any clarification questions? No.
Will you follow up for development of TB?
Yes, so the data will be matched to the enhanced TB surveillance system, which is our case notification system in the UK, and in a few years' time we will know what the reactivation is in that cohort, of course.
And you will monitor treatment completion?
That is inherent in the program, so that's one of the key indicators.
Because you didn't present.
No, that is something that, I don't know whether Matt Berman is in the audience, but he will present that separately.
Okay.
All right. Andy, can we keep it for the discussion session? Right, so we're going to move on to the second set of 4 presentations, and our first speaker is Jodie Boffa from South Africa. We'll be talking on community-level challenges to TB preventive therapy provision in KwaZulu-Natal in South Africa.
Thank you very much. So this is kind of fitting after the last presentation as well, just talking about challenges maybe at the healthcare provider level. So this presentation is talking about findings that were part of a larger study on isoniazid preventive therapy effectiveness and acceptability. And in South Africa, IPT is given as a 6-month regimen offered free of charge to prevent presumed latent TB infection from developing into TB disease amongst people living with HIV on the basis of a symptom screen to rule out active disease. Umgungundlovu district, where we did the study, is located in the province of KwaZulu-Natal, which is the province with the highest burden of TB and HIV-related TB in the country. This presentation focuses on the acceptability piece of the study. I'll present the effectiveness findings later this week in the student late breaker session. And it draws on ethnographic data in 3 communities that was collected between 2011 and 2015, including focus group discussions with various populations and interviews with patients offered IPT. We focused here on how the introduction of IPT affects explanatory models of TB. So while the simple answer came out shortly after our community work began, the more difficult task was to get beneath the sort of public transcripts that parroted an ad campaign that was often played on the radio at the time, sponsored by the government in collaboration with a foreign aid agency. So the words "prevention is better than cure" echoed from community members' mouths at the beginning of our interactions and often rang in my own head during the ad campaign, but truthfully, I never could figure out what the ad was promoting or preventing. Through the time in the country and through a lot of interviews and conversations and community engagement, we got to the hidden transcripts around IPT, which is that prevention can be dangerous. So specifically, there were 3 ways that patients thought prevention can be dangerous. Because of the high HIV prevalence in this area, which is between 15 and 20%, and the rapid scale-up of ARTs in the last decade, daily pill taking is typically seen as an indication of one thing, and that is that you have advanced to AIDS. So there was just stigma associated with taking pills daily, and so people that chose to take IPT weren't exactly talking about it and didn't want even their family members to necessarily know they were taking it, which meant that in general, the public really didn't know what IPT was unless you were a person living with HIV and you had been offered it. IPT also had the potential to make a well person sick, or to bear further burden on people who were already living in precarious life circumstances. For example, if it's not taken with food, IPT can cause stomach upset or diarrhea. But some participants also noted that taking IPT increased their appetites. So for 2 participants, this was enough for them to stop taking the medication because they just already had food insecurity in their home, and needing to take more food was a reason to stop it, and this wasn't something they were prepared to share with their care provider. Another participant had received a prescription to initiate food parcels, but to assist, in order to assist with her IPT, but she didn't know where to take the script, and again was too intimidated to ask the care provider. So the third potential way that prevention could be seen as dangerous is in the need for cleansing. So in Zulu culture, cleansing through the induction of vomiting or the use of enemas with or without the aid of herbs is not uncommon as a daily, weekly, or monthly practice to clean out the system of harmful toxins. So in these communities, one thing that's seen as a toxin to the body that would need cleansing is illness. Illness is seen as dirt that builds up mainly in the gut. And so when someone starts to feel symptoms, that might actually be a reason to start doing more cleansing or initiating it if you weren't doing it already. But the other interesting thing is that IPT and other daily regimens such as ARVs can also be seen as a reason to cleanse because it's seen as a poison that's killing the disease in the gut. So you don't want that to build up too much, and so you might induce cleansing just to make sure that it doesn't continue to bother you. So in essence, what the hidden transcripts taught us is that firstly, the well-intentioned ad campaigns, while catchy, don't necessarily translate into an understanding of the message or an engagement in dialogue around what prevention as opposed to treatment actually means. But part of the problem is that the health messaging is basically coming from sort of a Western, more biomedical model, which is people who are coming mainly from individualist backgrounds and wealthier backgrounds, and they might presume that the medication in and of itself and the adherence to it is the goal that's trying to be reached. But clearly the understanding from the local context shows that prevention can also be seen as an unnecessary burden for patients living in poverty with already many day-to-day struggles with health, with access, and with basic needs. So the implementation, the lesson for implementation would be a focus on working with the health providers to encourage more patient-centered care through initiating a dialogue with patients, who in this setting would rarely initiate a dialogue themselves because of obvious power differentials. So we have made a few sample suggestions of how a dialogue might start and how it could help care providers to assess the socioeconomic needs on a per-patient basis, and also encourage patients to decide if prevention is right right for them, but also have the buy-in for them to come back if it turns out that prevention isn't right for them, and have a further discussion with their care provider. So these are the questions. It's going to go a lot more in detail to that in the manuscript, so I encourage you to watch for the findings to be published on this. Thank you.
So thank you for saving us some time. If there are any questions for clarification? Not. All right. So we're going to move on to the next person, which is my co-chair, Annette, who will be talking about diagnostic accuracy of a novel CTB skin test for LTBI, results from the 2 phase 3 results.
Okay, so I think I don't need to convince this audience of the importance of detecting and treating LTBI. I'll skip the introduction and go straight to the point. A recent systematic review has shown that has used for the first time this term cascade of care applied to LTBI management. This systematic review has shown that losses occur in all steps of the cascade, so that at the end, less than 20% of those intended to be screened complete treatment. And main losses occur in the first steps, meaning identification and testing of those intended to screen. More than around 30% loss. So treatment default is just the tip of the iceberg. Many losses occur prior to treatment prescription. So we tried to understand our own cascade of care in Brazil, and this was part of a broader, more comprehensive project where we would try to understand why these losses occur and to implement solutions in 12 clinics located in 3 different high-burden cities in Brazil. The study was conducted in 2 phases. The first phase was a diagnostic phase to evaluate where the losses occur. So this is what I'm going to present today, the cascade of indicators. And this refers to the last period where PPD was fully available in the country. We also interviewed healthcare workers, index cases, and contexts to try to understand why these losses occur, and this will be presented in the poster section, not tomorrow, but Saturday morning. The second phase is an implementation of solutions that are discussed with local TB managers and clinical staff in each clinic based on findings in the first phase. So the cities are located in different regions. They have political, geographical, demographic, and even health system features very different one from the others. And of course, we are having different findings and different solutions are being discussed as well. Sources of data are multiple because there is no one registry where we can have all this information. So we looked at some clinics have a PPD book, others have the index case book, the pharmacies, the medical records. We try to find information everywhere. And this is what we found in these 12 clinics during this 6 months. 339 index cases were assisted, and only 814 contacts were identified. This makes an average of 2.4 contacts per index case. Less than 9% of them were tested, so this is a loss much higher than was shown in the systematic review. We also had a lot of losses in the TST reading, so 16%. This is much higher than the 6% found in the systematic review. 37% were positive, TST positive. This is in accordance to the literature. And interestingly, all of them were prescribed treatment. 2/3 of them were completed treatment. This is also in accordance with the literature. So clearly, in Brazil, in these 12 clinics, losses occurred mainly in the first phases of this cascade. So this is what I show when I go to the clinics to show the results. I do the math with them. I say, well, if we do an intervention at the end of the cascade, say if we have a wonderful treatment, a one-dose treatment with 100% of adherence and tolerance, we would still have only 27 persons completing treatment. While if we act here, say if we have 4.2 contacts identified, as shown in another systematic review, and even having a lot of losses for PPD reading and a very low rate of adherence, we would still have 15 times more patients completing, not patients, but contacts completing treatment. This would avoid around 26 cases of TB, which is around, it's almost 10% of the TB load in these clinics. So in these 12 clinics, we could show that we are missing an excellent opportunity to prevent TB. This is being shown in the clinics. We could have avoided around 26 cases only in these 12 clinics in 6 months. Main losses precede adhesion to treatment. So when we discuss with the healthcare workers and they say, oh, they want adhere, and I always answer, this is not a problem of adherence. This shows that more than a new, shortened, and well-tolerated treatment is needed. I'm not saying this is not needed. It's also needed, but more than that is needed. And this cascade shows us where the losses are, but not why these losses occur. So we have gone further. We have interviewed healthcare workers, index cases, and contacts. This will be shown Saturday, and we are already moving forward phase 2 as well. Solutions have been very different according to the clinics. I hope you will soon hear from us. Thank you.
Thank you very much. Any questions for clarification? David, clear presentation. Right, we're going to move on to the next presentation, which would be Larissa Otero from Peru. We'll be talking about the uptake and completion of RPT among household contacts of TB cases in Peru.
So good afternoon. I'm going to present the preliminary studies of an ongoing study in Lima, Peru. We're studying the uptake and completion of IPT among household contacts of TB patients. Should I do something?
Someone is sleeping.
Can you put on the slides, please?
Not working. Okay, great, thanks. So the Americas is the region with the lowest burden of tuberculosis in the world. However, Peru, with 31 million inhabitants, composes 3% of the population, but contributes to 13% of TB cases and to 42% of MDR TB cases. Incidence is 119 per 100,000. We have a low HIV prevalence in the general population, and we have a structured national TB program with DOT centers in almost all public health facilities in the country. The Peruvian guidelines recommend that all household contacts should be investigated, and a 6-month course of IPT is recommended to household contacts of drug-susceptible TB index cases and to all those under 5 that do not have active TB, and regardless of the TST result, and to 5 to 19-year-old contacts with a positive TST. However, because of the recent stock out of PPD, TST has been prioritized as a tool to diagnose active TB among younger children and not to determine eligibility of contacts 5 to 19 years old. The boxes below show the full process of household contact identification, as we have also seen in the previous presentation. However, for this presentation, I will present only the last two parts, start of IPT and completion of IPT. We're still collecting and cleaning the data from the previous ones because it also comes from different sources which vary in between the health facilities. So this is a retrospective longitudinal study to determine uptake and completion of IPT among household contacts of pulmonary TB patients. We have included 12 health facilities in 2 large districts in southern Lima. We will present the preliminary result of 9 health facilities. All persons started on TB treatment and their household contacts have been included, and we excluded extrapulmonary TB cases and MDR TB cases. The study period is from January 2016 till July 2015, till July 2016. We have revised TB treatment cards, which have the contact investigation form on the back, and the clinical files of the index cases and, when existing, of the contacts. So caretakers have to go weekly to pick up a weekly dose of IPT during 24 weeks, and adherence to IPT was measured by these weekly pickup refills at the DOT center. So in the study period, 515 cases were treated for TB, and after excluding extrapulmonary and MDR, and those with no information on household contacts, we had 359 index cases with pulmonary TB and 1,480 household contacts. That's a median of 4 household contacts per index case. Among the household contacts, 12 were under 5 and 27% were 5 to 19. So to note, that makes 1.6 contacts in the age group potentially eligible for IPT for each pulmonary TB case. Considering that in a health facility, the staff assigned to the TB center is composed of 3 persons, a part-time doctor, a sometimes part-time nurse, and a full-time nurse aide, and they have to conduct case detection, TB treatment directly observed, and they have to prepare MDR TB files. That's a lot of workload. In addition to household contact investigation of all, to in addition provide IPT to potentially 1.6 contacts per case, it's an important workload to consider. So in this graph, in the first bar, we see the number of eligible contacts, and then in the under 5, which means we excluded all those that had active TB at diagnosis. In the 5 to 19 years old group, this should have also excluded those who were TST negative, but TST was not done. So 60% of under 5 years old were started on IPT, and only 23% of them completed IPT. That's 14% of all eligible. That's quite low. An even lower proportion of 5 to 19-year-olds were started on IPT. This may have been due because of absence of TST and prioritization of under 5, but also a very low proportion of them completed IPT. Here we see the dropouts of IPT in only the contacts under 5 years old per week in the 24 weeks of treatment. And we see, despite we had dropouts at every week, the largest proportions were at week 6 and at week 13. There were large variabilities per health facility. 2 health facilities, and almost 3, reached more or less high proportions of starting IPT. However, completion was low in almost all of them, and even 0 in 4 health facilities. The high proportion in some health facilities of starting IPT suggests that it could also be improved in others. So when analyzing determinants of uptake and completions, we saw that contacts of the most infectious cases were more likely to be started on IPT than those of SMER negative index cases and those of index cases with scanty AFB bacilli in their sputum. Then among 96% of contacts completing IPT were contacts of an index case who completed treatment successfully, as opposed to only 65% of contacts not completing IPT. So this is indirect, but could suggest that in household where the index cases completes IPT, the contacts are also more likely to complete IPT, so that full compliance to TB recommendation happens in clusters in households. Then importantly, among contacts under 5 years old, the completion was very low among those less than 1 year old. 10% of them completed IPT, which is quite serious, as the risk is even higher among them, while 28% of those 1 to 5 years old completed IPT. So we conclude that in our setting, we had a moderate to low uptake of IPT among under 5 years old and a very low among 5 to 19. Completion of IPT was low in all groups, and especially among the youngest ones. There was a large variability between health facilities. Contacts of the most infectious cases are correctly prioritized. This study is ongoing. We will complete 3 more health facilities, and we will also analyze the steps prior to those shown here to see how many were examined and which tests were done to all. And also we conducted a qualitative study to understand the reasons behind the staff and the caretakers for not complying to this. Interventions to increase IPT uptake and completion are urgent, but however, for this we have to secure resources and especially designated time from human resources to comply with recommendations that do not take time away from case detection and treatment of TB and MDR-TB, which should be the priority. Currently, with 3 persons appointed to all TB management in a health facility, in high incidence settings such as the study districts may be very difficult. The use of shorter preventive regimens would be great, but the current available, the 3HP, is not, cannot be used in under 2 years old, so they still should be using IPT. I want to acknowledge the Institute of Tropical Medicine, the University Cayetano Heredia, with whom I conducted the studies, the National TB Program for its collaboration, and the Belgian Corporation for funding the study, the co-authors shown in the first slide, and the field workers and district TB staff for this study.
Any final comments around, not comments, but questions for clarification?
I'm Vanessa from Rio de Janeiro. I would like to know what you do for MDR contacts, and if you do GST culture and GST for all TB patients because of your high burden of MDR.
Yes, since November 2013, all TB patients are screened for MDR-TB with rapid tests, and those positive have a solid DST done. And contacts are just observed, so no prophylaxis is given, and they are observed for every 3 months during the 18 to 24-month treatment of the index case.
One other question for clarification.
You said that workload may be a problem because these are TB service personnel. Are there other primary healthcare personnel who look after other aspects of health, in child health, maternal child health, who you might consider doing contact investigation?
Yes, there are. There's a maternal child unit in every health facility that sees vaccination and normal child health care. And yes, it could be a possibility. Actually, I have never thought about that or heard about collaboration with that, but
Bangladesh, we've just completed a 1-year study in the USA funding where we've used, in one district, we had 1,700 sputum positive. In our country, it's a contact investigation only for sputum positives. And in that district, there are 800 such primary healthcare staff. So that comes to only 2 contact investigations a year that these people have to do, which is no load at all compared to using TB staff who are busy with many other things. So we tried to implement that. And although there's some initial resistance, but I mean, if you show them the figures that it's not a huge workload, it may be possible.
Well, thank you for that. Right, we're going to move on to the last presentation. So Roman Reganat from Australia will be talking to us about is isoniazid preventive therapy more effective in high burden settings and modeling the effect of TB incidence on IPT impact.
Good afternoon, everyone. So I'm going to talk about IPT and more specifically about a modeling study looking at the relationship between TB incidence and IPT effectiveness. So I don't want to remind too much details about LTBI because we've heard about that during this whole session. But just to summarize briefly, we know that there is a huge burden of latent infection. But what we don't know is what is the actual risk represented by this reservoir. And it's really hard to assess this risk before, because as we heard from the previous speakers, LTBI is complex to diagnose. And it's impossible to predict whether an infected individual will eventually progress to active disease. But what we know about disease activation is that it can basically happen at any time after infection, but the reality is that it mostly occurs soon after infection. Just a few words about IPT. While we know it's effective at the individual level, it remains unclear whether it's effective at the population level. There are some evidence showing that it's effective in reducing TB incidence in some areas, but the recent trial conducted in South Africa demonstrated no long-term global level, population level impact. So there is a lot of uncertainty about this population level impact. And in addition to this population level impact, it remains unclear. What remains unclear is the mechanism of action of IPT at the individual level. Does it cure infection, or does it partially reduce the risk of activation? And the main question we wanted to investigate in this study is, where should we use IPT? And in particular, in what kind of incidence setting? So we might be tempted to use IPT where there is a lot of latent infection around, and particularly in these dark red areas here. But what we know is that these areas are also those where there is a lot of TB transmission because TB incidence is high. And that means that these are the places where you are likely to face issues around reinfection. And we know that reinfection can counter the effect of IPT. And this is why WHO recommends provides different guidelines for different TB incidence settings. And more specifically, these guidelines are less in favor of IPT use for high burden settings. But despite of that, despite of the fact that we can anticipate some link between TB incidence and IPT effectiveness, we actually don't know about the real relationship between these two entities. So what we wanted to do is to use a transmission dynamic model that I will detail on the next slide in order to investigate the population level effectiveness of IPT under various levels of TB incidence, as well as different scenarios for the individual level of IPT efficacy. So this is the model that we used. It represents a population which is stratified into different categories, each with different characteristics. The first one, the S compartment, represents a susceptible population. These are individuals who are not infected with MTB. The red compartment, the I compartment, is for active disease. And you can see that between the S and the I compartment, you have these two compartments representing TB latency. And the reason why we use two different compartments is in order to simulate two different levels of risk. One for the early stages of infection with a higher risk of activation. And for the late stages of infection, we consider a lower risk of activation. And then after cure, you get to this compartment, which is kind of a recovered compartment. In the model, we can also include reinfection, which means that you can get back to this early stage of latency, even after cure of TB, or even if you are in the late stage of infection. And in order to simulate treatment for treatment for latency, we actually use two additional compartments that are actually the clones of these latency compartments, but to which we will apply different characteristics in terms of risk of progression. So if you consider these two parameters, gamma and nu, that represents the rate of progression to active disease, we use this same parameter, but we associate a multiplier which will permit to reduce the risk of progression to active disease. And the advantage of using this kind of multiplier is that we can consider various levels of efficacy. The most optimistic scenario would be where this multiplier is equal to 0. That means that you are breaking these two links and there is no more activation for treated individuals. So here are the main results. I am representing the number needed to treat, which is basically how many preventive treatments you have to provide in order to prevent one case of active TB. So what we want to do is basically to minimize this indicator. And while we were expecting some increasing trend over TB incidence because we thought that it would become more difficult for IPT to have an impact in higher burden settings, what we actually observe is U-shaped curves. And this is true regardless of the scenario considered for the mechanism of action of IPT. And what it indicates is that the optimal level of incidence for IPT use may actually be somewhere between 500 and 900 of incidence, which is really high incidence setting. So we wanted to understand the explanation behind these U-shapes that were kind of unexpected. And we identified two different phenomena. The first one were anticipated. This is where you look at the risk of reinfection when you increase TB incidence. And we can see that reinfection is increasing over incidence, which will lead to a negative impact for IPT effectiveness in high burden settings. But there is another factor that we are highlighting in this study. And this factor will be actually going in the opposite direction. If you compare these two diagrams here, one for low burden setting, one for high burden setting, what we can see is that in a high burden setting, this latency reservoir represents a much higher risk of activation. And this is actually due to reinfection once again, because reinfection will drive people who are in these late stages of infection back to these early stages of infection. So that means that in a high burden setting, this latency reservoir is at higher risk of activation, which means that treatment becomes more interesting because you are treating people at higher risk. So you have these two compensating phenomena that explain these U-shaped curves. And you can also find a confirmation of this phenomena explained here if you look at this curve representing the proportion of disease coming from recent infection versus late stages of infection. So the take-home message from this study is that the optimal TB incidence for IPT use might be much higher than previously thought, somewhere between 500 and 900 of incidence. And another thing that we highlighted in this study is that, well, reinfection was known to counter the effect of IPT, but what we highlight here is it also has a synergetic effect. It can also be seen as a booster for IPT efficiency. And I think it's critical to take that factor into account when designing policies for IPT use. So the main limitation of this study is that we employed a very simple model structure. And the reason for that is we wanted to keep a full understanding of the model dynamics and model behaviors, but future works could be much more applied and looking at some countries in particular, and therefore incorporate some more details regarding age, HIV status, or comorbidities, or drug resistance. So I'd like to thank the different contributors of this study and the funders. Thank you very much for your attention.
All right, thanks. Are there any questions of clarification? Yes, one.
Sure, William of USA. Were the side effects of the IPT taken into account in the whole modeling of adverse events?
So they are not explicitly taken into account in the model, but this is also the reason why we chose NNT as the main indicator, because NNT will take into account the number of treatments provided and not only the impact of IPT. So it's not taken into account explicitly, but more implicitly.
All right, so we're now going to move into the open discussion period. So unfortunately, we don't have enough chairs up here. But if I could please just ask the speakers to maybe just stand up just to remind everyone who you are. Okay. All right, so we've got 10 minutes for some questions. Andy, do you want to start with your... So if you can maybe just try to identify who your speaker was, and then they can stand up and speak. Yeah, please sit down until... Andrew, you had a question. So treatment completion in the UK. So we're battling to hear you, Andy. Or do you want to just quickly comment about treatment completion rate?
Unfortunately, that's a very quick comment because I didn't present any treatment completion rates. That's a different topic. We only presented treatment initiation rates, and there were 62% of those people that were eligible.
Okay, but you said you were going to measure treatment completion rates. Yeah. Okay. Any other questions? Yes, Ken.
Thank you. First of all, I really enjoyed all presentations. Larissa, Daryl, my question to you is actually it's a two-pronged question. Does Peru have the ability to, do you have rifampicin registered if you wanted to use Heineken rifampicin as a short-term regimen, which you suggest might be a way to overcome the low completion rate? And then the second question, also leading to that conclusion, can you show that the fallout over time, like, how many people complete 2 months of isoniazid preventive therapy as opposed to the 6 months, which would reinforce the solution, I'm sorry, the use of a short-term regimen as a potential solution for your situation. But thank you.
So no, at the moment we don't have rifampicin in Peru, and it's expensive and a bit complicated to get it, but we are interested in doing it, and we'll have to discuss with the TB program to see if that's feasible, and if it would be directly observed or not. Regarding the, if I understood well the question, so at week 12, we had about 50% of patients lost, no? And the largest drops were at week 6 and at week 13. So yes, that would go very well with rifampicin, which as it's only once a week, it would be very easy to make it directly observed as opposed to the daily use of isoniazid.
So Jonathan has just walked in. Do you want to just comment quickly about Brazil's plans to get rifampicin?
Okay. I mean, that probably has a little bit more detail than I do.
Well, why don't you comment then?
Brazil is now, we have a free public health system, but we have an interesting mechanism, which is a commission inside the Ministry of Health that decides what is going to be incorporated or not. And we are shortly going to present 2 things to this commission. The first one is incorporation of quantiferin, and the second one is rifampicin. We don't have cost-effectiveness analysis yet, but we hope we will have soon.
Right. Any other questions? We had one. Yeah, thank you. I'll come to you now.
I thought it was very interesting that the last speaker sort of suggests we should all move to Southern Africa because that is where we have the rates that's where IPT may be most effective. But then Dr. Boffa has shown us that it's extremely difficult because of the understanding that the population there may have. So I think it is really very interesting that your research shows that we may need to listen and talk to the patients much more, because what is in our heads as medical people is definitely not in the heads of many of our patients. And this morning I was in a session where we talked about LTBI in Syrian refugees. Well, for Syrians, they don't have TB unless you're poor. So, I mean, that sort of perceptions come into it as well. And I think this is all very interesting. And we may need to do a lot more around that. So maybe that was more a comment than a question, actually.
So just out of interest on that modelling paper, George Comstock always said your best vaccine is infection followed by treatment. So I'm glad you confirmed. Yes, Masai first.
But they're not. So no, the sensitivities are based, we explicitly said we're not going to base it on prevalent active TB. It's actually based on number of children who, presumably some of whom were contacted, this is from the literature, exposed to TB probably in some way, tested with the test, followed over time to see who developed TB. So it's a very simple, it's like a poor person's made analysis, just sort of crunching the numbers together. But they're pretty consistent, and even with the pretty large amount of data we have from the testing itself, what we got out of the final post years for that, the final result was very consistent with what was seen in the literature, which is, yeah, they're all pretty poor.
Right, we're going to take the last two questions. Stephen, you, and then we'll carry on.
Yeah, no, we broke so that there's, actually there will be, I think Saturday afternoon, there's a poster on both on HIV positives and another one on, or e-poster on over 5s. But yeah, we collapsed the under 5 because yes, even within, there's a difference immunologically between 1-year-olds and 4-year-olds. But when you get into those fine gradations of numbers, we thought that what you might get in terms of precision would be sort of outweighed by the spread in the confidence intervals. And I think that probably the key message here is I think it matters in some sense very little, because what you would expect to see is, yeah, as you get younger and younger, the sensitivity might go lower and lower. I would argue the sensitivity is so bad already, I don't care all that much.
Last question, Steve.
Yeah, thanks, Gavin. It's just, I guess I'd like to just reflect in relation to the issue of adherence to IPT in children. There's been a project that's been rolling out in Vietnam. The National TB Program in Vietnam has been rolling out community-based contact screening and preventive therapy. And there's now 16 provinces engaged. So we're now talking experience from around 10,000 children under 5 eligible for IPT. And the adherence that they're getting is better than 85% for 6 months of IPT. And from this just observation of why that might be, I think, to me, the two things are that the people who are responsible for providing adherence, monthly follow-up, weighing the child, the same community health workers who are providing care for the index case with TB. And there's a good relationship in that context, particularly in the rural areas. But also the Vietnam program gives an incentive, a financial incentive, to the community health worker for completion of 6 months of IPT. So just that I'd share.
Very cool, thank you very much. So just before I make the concluding comments, I just want to be sure that the audience doesn't leave with the idea, following Roman, your last presentation, that we should be using IPT in low incidence settings. Within the context of an elimination agenda, it may be harder. You may need to treat more people to prevent a case, but it absolutely has a role. And even in low incidence setting, there's great heterogeneity. So please, the message isn't that it doesn't have a role.
So we found that for low incidence settings, we have like quite a high number for the NNT, which is not so good, but what we also show is that if we target the right population, the ones that are infected that have been infected recently, then you can have a higher impact.
Right.
Because this is this effect that counters the effect of IPT.
Well, just to thank our speakers very much, please give them another round of applause. Thank you for your participation.